Assalamu alaikum. I would like to welcome our distinguished speaker, commentators, and attendees. All of you are welcome to the second infectious disease wave, which is a fruit of the scientific collaboration between United Conference of Hepatogastroenterology and Infectious Disease and the Infectious Disease Department at King Abdulaziz University, Kingdom of Saudi Arabia, headed by Professor Tariq Madani, without whom this work would not have come to light. I would also like to thank Professor Dr. Reham El-Kaki, Associate Professor at King Abdulaziz University Hospital, Dr. Ahmad El-Kurdi, Lecturer of Hepatogastroenterology and Infectious Disease, Cairo University, for their great efforts to produce this scientific meeting in this appropriate manner. I hope to enjoy our scientific meeting today. And now I will leave the mic for our distinguished commentators to introduce themselves alphabetically. Dr. Abir Ashukeri, Dr. Ahmed Saad, and Dr. Nesreen Rizk. Dr. Abir.
Assalamu alaikum jami'an. Thank you so much for the invitation. I'm so happy to be with you this evening. I'm actually at head section of the infectious disease section at King Faisal Specialist Hospital, Research Jeddah. And I hope we'll have a wonderful evening discussing the various aspects of fungal infection of these. Thank you.
Thank you so much for our colleagues and friends and our professor, Dr. Tariq, with us also. And thank you for the organizing committee. I'm Ahmed Saad, consultant internal medicine and infectious diseases, Cairo University, and working as a consultant internist in Arfan Hospital.
Nesreen?
Okay, well, good evening. My name is Nesreen Rizk. I'm an infectious disease physician. Currently working at the American University of Beirut Medical Center. Hello, everybody, and good to be with you here today. Thank you.
Thank you, everybody, for your introduction. Shukran, Dr. Maisa, for the introduction. I'm Tariq Madani, Professor of Medicine and Infectious Diseases at King Abdulaziz University in Jeddah. And it's my pleasure to introduce our speaker today, Dr. Sharik Haidar, who has completed his MD degree at the University of Saskatchewan in Canada, followed by 4 years of internal medicine training at the University of Toronto in Canada. He went on and completed his infectious diseases fellowship at Henry Ford Hospital in USA, and then completed his diploma in tropical medicine and hygiene in London, UK. He received his CSST in internal medicine from the UK. Dr. Haidar is Professor of Medicine in the Division of Infectious Diseases, Department of Medicine at McMaster University. He's an infectious disease and internal medicine consultant at Hamilton Health Sciences. He's the past program director for McMaster Internal Medicine Residency Program. He's a surveyor for postgraduate training for the Royal College of Physicians and Surgeons in Canada for both Canadian and international programs. He's been involved in infectious diseases and HIV care for the past 20 years and is the current medical director of HIV. He'll be talking to us about three important fungal topics: invasive aspergillosis, and then mucormycosis, and then invasive candidiasis. Please, the floor is yours, Sharik.
Thanks very much, Dr. Madani. And it's a pleasure to be here this evening. I wanted to start by actually thanking Reham because, despite a very busy schedule, when an ex-fellow contacts you and says, "Are you willing to do a talk?" it's very hard to say no. So you can give her full credit for me being here this evening. But it's a pleasure to be here, and I've had the opportunity in the past to come to Saudi Arabia in my role as the Royal College accreditor, and I think I've actually met some of you at many of the centers. So a pleasure to be here, and I look forward to the discussion today. So with that in mind, I'll see if I can share my screen. Okay. All right. Well, I'll try. I think I'm on now. Just give me a thumbs up if you can hear me. Yeah, I think you can all hear me. Yes.
Yes. Yes.
Perfect. Okay. So the topic is invasive aspergillosis. We have about 20 minutes to kind of overview this topic, and then look forward to some of the discussion. Sorry, give me 1 second here. This has happened before. 2 seconds. Okay, I'll skip that. So the objectives today are to overview the epidemiology of invasive aspergillosis. This is a bit of an evolving topic because our risk groups have really changed. I lead and help develop a service here called the Transplant and Malignant Infectious Disease Service. So I exclusively see cancer and transplant patients, but it's come to, certainly all of us have realized that the risk groups for aspergillosis have continued to expand and evolve in the last decade. We'll talk about some of the developments in diagnostics and particularly some of the revised classifications of invasive aspergillosis. There are consensus guidelines and recommendations around defining invasive aspergillosis. We'll update some of the new treatments for invasive mold infections and then open it up for discussion. So, emergence of mold infection, of which Aspergillus is the most common mold that we see, is continuing to rise. And why is it so? Well, because of a number of factors, certainly selective pressure from prophylaxis. Since the introduction of voriconazole as a potential oral drug for prophylaxis, we've certainly seen an expansion of mold infection. There's certainly been a much lower threshold for empirical therapy. For those of you that have been around in the past, when we had ambisome, we were reluctant to use the drug unless it was absolutely indicated. But now that we have got drugs with wider therapeutic indexes, there's a liberal use of antifungal therapy, and that certainly contributed. And then without question, there is an expansion in the number of high-risk patients, and we'll get into that. The flip side is that we have challenges. We still have advancements, but still challenges in diagnostics. We have antifungal agents. We've certainly expanded the armamentarium, but even in today's antifungal world, there are challenges of adverse effects, drug-to-drug interaction issues, and at least in this part of the world, we say cost is a big issue, at least in Canada. So Aspergillus for all of us is very much an opportunistic pathogen. It does not occur in people with normal immune systems. So let's just set some framework. Aspergillus fumigatus is the most common species of Aspergillus, is the leading cause of invasive mold infections. But it should be said that there is a spectrum of disease seen with Aspergillus. On one end, we have patients who are immunocompetent and can develop ABPA, allergic bronchopulmonary aspergillosis. And then on the other extreme, we have people with invasive pulmonary aspergillosis, sometimes CNS presentations with isolated aspergillomas. But what are some of the concerning trends? Well, one of the concerning trends globally is the emergence of the non-fumigatus strains. And certainly they will vary by region. And I'll be interesting to hear what you see in Saudi Arabia and in Lebanon and certainly in Egypt. But certainly where I practice, we're seeing an emergence of non-Aspergillus fumigatus with Aspergillus terreus, certainly being very common, Aspergillus niger and nidulans. And then an emergence of what we call cryptic species of Aspergillus, Aspergillus felis, lentulus, Sidovi, pseudodefectivus. And these are important because often these are, in fact, resistant to a number of the available azoles that we have. The other big concern these days is the issue of resistance, which is not as much of an issue in Canada, but I suspect may be an issue where you're practicing. And certainly the azole resistance associated with the CYP50P51 mutation is globally on the rise, and certainly that affects our ability to treat this infection effectively. I won't go through all of this, but I wanted to highlight that there has been an expansion in risk groups, and much of the reason for the expansion in the risk groups has been the development of new immunomodulating agents in both the solid tumor world and certainly in the malignant world. And so just a couple of examples, BTK inhibitors, ibrutinib, acalabrutinib, which is used for CLL, is certainly associated with hypogammaglobulinemia, and that translates particularly with the risk of invasive aspergillosis, particularly CNS aspergillosis. We've seen a number of cases around that. The expansion of standard therapies for AML. Examples are these BCL2 inhibitors, venetoclax, which impairs dendritic function. The effect of that is prolonged neutropenia, but also reduced interferon production. And though overall the risk of opportunistic infection is low at 3%, we do see cases of invasive aspergillosis. But certainly the other big risk factor, certainly where we do see the risk of invasive aspergillosis, is these BCR-ABL inhibitors, imatinib and dasatinib. Again, agents that are used certainly here for management of CLL. It affects CD34 dendritic cell differentiation, certainly impairs reduced T cell activation, and the translation can often be that of increased fungal infections. There's obviously expansion of for other agents, JAK2 inhibitors, proteasome inhibitors, and the like. But the big ones for IA, invasive aspergillosis, the BTK inhibitors and the BCR-ABL inhibitors. So if you wanted to classify risk groups, and in fact, if you're going to do a clinical trial today of a new interventional agent for invasive aspergillosis, you want to pick the highest risk group. And the highest risk group for invasive aspergillosis, without question, is allogeneic transplant patients who've suffered graft versus host disease. And that's followed then second by AML or MDS patients undergoing remission induction chemotherapy. Those without question are the two highest risk groups. Now, there's a host of other groups, solid tumors, of which lung and heart transplant obviously are the most common. Certainly, patients with ALL can certainly get invasive aspergillosis, but lower. We just want you to remember that the top two groups would certainly be allogeneic transplant GVHD and AML MDS induction. But the other expanding group are patients on T-cell immunosuppressants, right? This was not there previously, but it's something we have to be certainly vigilant of, and we talked about that in the previous slide. People on long-term prednisone, 0.3 mg per kilogram per day for greater than 3 weeks. And then I'm sure all of you have become familiar with the association with previously with influenza, and now the association with COVID-19 and the risk of invasive aspergillosis. So can't forget that. Now, if you look at your two highest risk groups and you focus in on AML induction chemotherapy patients, the timing of invasive aspergillosis typically tends to be day 21 to 30. And that's been really important, at least in shaping treatment protocols in many of our cancer centers. So as an example here, we have adopted expanded azole prophylaxis for AML patients. We now use posaconazole prophylaxis. And part of the reason, again, was that we were seeing rates of invasive aspergillosis as high as 9 to 10%. And usually the median time you'll see it is day 21 to 30 of induction chemotherapy. What about in the highest risk group, the allogeneic transplant group? What is that rate of invasive aspergillosis? Well, we can refer to either observational studies or we can refer to the prospective clinical trials. I'll take you to the prospective clinical trials and I'll tell you to leave out the MARC study. Now, we've been involved in all these clinical trials, but I'll take you to the Ullman. The Ullman paper is, in fact, the paper looking at the role of posaconazole versus fluconazole or prophylaxis in grade 2 higher GVHD. If you look at the placebo arm, you'll see that the rate in the placebo arm was 9%. Sorry, in the placebo arm, in the fluconazole arm was 9%. If you go to the Wingard study, which was a study again looking again at fluconazole versus voriconazole in allogeneic transplant population, the rate in the fluconazole arm was 13%. So if you remember a rate of 10 to 11%, which is not obviously not a negligible rate, that's what defines this as the highest risk group, a rate of around 10 to 11%. The observational retrospective studies are, obviously have confounders because they're retrospective in design and all so forth, but keep in mind 9 to 10%. If you try to estimate the burden of fungal infections and look at global data, there is literature out there. This is just a paper that I've picked for you from the European Journal of Clin Micro, which looks at sort of global distribution of fungal infections. I've just shared with you our Canadian experience that in Canada, the estimated rates of invasive aspergillosis are about 1.59 per 100,000 or about 500 cases on an annual basis. Obviously, that rate will significantly vary by region and certainly globally by where you reside. We did a cross-Canadian study just looking at our own rates of invasive aspergillosis in our tertiary hematology centers. The only thing I wanted to show you was that if you come to the rate of proven and probable invasive aspergillosis, which is the second line here, you'll see that the rate sits roughly around 9%. And that 9% is really important because that is the rate that was quoted in the posaconazole AML induction study. So if you're going to use external validity to implement an intervention, you want to have the same rates as the clinical trial. And the rate in the Cornelli paper in the fluconazole arm was around 9%. So we really felt that we had a burden of disease in Canada, and we certainly justified the introduction of posaconazole for prophylaxis. Now, every time you introduce an intervention, there's always a downstream signal, positive and sometimes negative. So one of the concerns when you introduce broad azole prophylaxis is that you may, in fact, shift the epidemiology. So this is a paper, again, by Lamoth and colleagues, just sharing that experience of the introduction of broad azole prophylaxis in their tertiary center. And what you see is that if you do not introduce broad azole prophylaxis and you just use fluconazole, what you would see as your typical distribution of invasive mold disease would be primarily aspergillosis, about 60%, right? And then you start seeing an emergence of about 15% mucorales species, followed by fusarium. But look what happens if you are, in fact, on broad azole prophylaxis, and then you break through. Now, only a quarter of your patients would be aspergillus, suddenly almost a third of your patients will be mucorales, and you start to see an expansion of these demaciaceous fungi, like Scedosporium as an example, and other molds take up a third. So this is the challenge of introducing broad azole prophylaxis, is that though it works, it's highly effective, the breakthrough rate is low, there is this selection pressure issue. Just another study, this is Dr. Herberg and colleagues. This was presented at ECMID a few years ago. It's now published. It's a 20-year experience at a university center. And obviously, over those 20 years, they shifted from a non-broad azole prophylaxis to a broad azole prophylaxis strategy. And the only thing I wanted to share with you is the other emerging trend that we're seeing is, you saw in the previous slide, an emergence of mucormycosis in patients who break through on broad azole prophylaxis. But this issue of co-infection, the issue of having aspergillus plus a second mold. So these are things that you would have to be vigilant about, and you would need to define your own local epidemiology if you implement broad azole prophylaxis, whether it's in AML patients or in graft versus host disease patients. Now, that's the bad news. Is there any good news? Well, there is lots of good news. The good news is that in the Cornell paper that led to the implementation of posaconazole for prophylaxis, the breakthrough rate in the IFI arm was only 2%, but that's a clinical trial. And we're always weary about clinical trials, right? Because there's selection pressures, there may be selection biases that are there. So what happens in real life? So this was the first real life experience out of MD Anderson, sharing their implementation of posaconazole for AML induction. And just want to share with you that the breakthrough rate was exactly the same as the clinical trial, 2%. So though, yes, we worry about breakthrough invasive mold infection, we're only talking about a 2% breakthrough. But the types of organisms, it's a spectrum. Penicillium species, Aspergillus flavus, Fusarium, and in many cases, you were not able to culture the organism. So let's shift to diagnostics. We have seen a significant evolution in diagnostics. I think you're all aware that unlike Candida, our ability to culture Aspergillus, particularly from, say, lung as an example, the sensitivity of a BAL for culture for Aspergillus is no higher than 30%. And that's a challenge. So obviously, we need non-culture-based methods to improve our diagnostics. And the good news is that we've come a long way. We still have a long way to go, all right? But at present, the new developments that have come in have been antigen detection. And I think many of you probably are familiar and are using galactomannan, which is now a non-culture-based assay for both diagnosis of invasive aspergillosis and actually response to treatment. But the future is going to be very much about nucleic-based testing and hopefully the issue of proteomics, right? Which is really exciting. This concept also using volatile organic compounds. This is the future for invasive aspergillosis. Just to tell you a little bit about galactomannan. So obviously it's available in almost, I think in most centers now, but just to remind people that it's not going to solve every problem. The sensitivity of galactomannan in the serum still sits between 58 to 60%. What about if you do the same test in bronchoalveolar lavage? So this is a systematic review published that shows that in the BAL, the sensitivity climbs quite well, up to about 87%. So certainly where we use the test is two places. We use it for confirmation of disease from our bronchoalveolar lavages, and we have now stopped using it for routine screening because of the poor sensitivity. And remember that this sensitivity is in the era of fluconazole prophylaxis. If you introduce posaconazole prophylaxis, that sensitivity drops quite significantly. So we really primarily now use it for disease confirmation and response to treatment. But the future is molecular testing. I can tell you that certainly where I practice, this is not a routine test that's available, but we hope to have it in the near future. Is Aspergillus-specific PCRs. The sensitivity quoted is as high as 72%, specificity of 96%. There's obviously the biggest challenge with molecular testing is standardization of your primers, right? So what you use in Lebanon may not be the same thing that I use in Canada. And so for the ability for us to be able to compare and contrast data becomes a bit of a challenge. But for sure, it is the future, particularly if you're going to introduce broad azole prophylaxis and you're concerned about breakthrough infections. There's also a pan-fungal PCR that's available. We have it available at our local Sick Kids Hospital. Again, the improved sensitivity, obviously, to culture, but it's not the solution for everything. And really, I think the future is going to be very much about combination diagnostic testing, kind of using these tests for their negative predictive values. So a negative PCR with a negative galactomannan to exclude people that have invasive aspergillosis. Because this is pan-fungal, obviously, it may be useful in mucormycosis as well. What about the future? The future is about looking at biomarkers. That's really exciting, this concept of using pattern recognition molecules for diagnostics. the concept of metabolites, this volatile organic compounds, because what's the biggest challenge, and I'm sure you're going to agree with me, you have a patient that is post-transplant or post-AML, he suspected invasive aspergillosis. By the time you see the patient, they're already on 50% venti mask or high flow nasal oxygen. Nobody wants to bronch them, so you can't get a specimen. So we need better tests that are easily accessible in these patients. And that's where, breath tests, sputum analysis, blood samples become really important. So the future certainly looks promising. Now, I think most of you are familiar with the fact that we do have a standardized definition for invasive aspergillosis developed by two bodies, EORTC and MSG, but it has recently been updated, the criteria. So I won't spend, I just wanted to show you that this is the reference for it, but I'll just walk you through that the categories are the same: proven, probable, and possible. Proven obviously requires the presence of tissue confirmation, histopathology, direct cytological examination, or culture from a sterile site. BAL is not considered a sterile site. Most of the time, we don't have proven invasive aspergillosis because we don't often get tissue samples. So we live in a world of probable invasive aspergillosis. And that's a mix of host factors, which you're seeing, but this has been the new development, has been the expanding group. And I referenced that earlier in my presentation. It's no longer just about AML induction and graft versus host disease and transplants. Expansion with steroid use, expansion with T-cell immunosuppressants such as calcineurin inhibitors, TNF-alpha blockers, lymphocyte-specific monoclonal antibodies, and treatment even with B-cell immunosuppressants. We talked about the BK inhibitors as being a big risk group now for invasive aspergillosis like agglutinin. And then the other big change has been the cutoffs for defining the microbiological criteria. The clinical criteria hasn't changed. It's very similar to the previous criteria. If you're talking about lung disease, classically you're looking for this concept of a halo sign, which is an area of essentially of infarction surrounded by a zone of hemorrhaging. That's what the halo sign is. Or you're looking in patients who have decent counts for air crescent sign. I always tell my fellows that the best way to think about invasive aspergillosis is like a pulmonary embolism. It's the same histopathology, right? It's an angioinvasive infection that causes damage to the intima and media of lining of blood vessels, causes microthrombi. So think about all the things you think about a PE, right? Think about Hampton's hump. Well, guess what? Hampton's hump shows up here, wedge-shaped, pleural-based consolidation. If you see that in the right patient, think about invasive aspergillosis. But the biggest change has been these cutoffs. So the galactomannan cutoffs used to be 0.5, both in the serum and BAL. They have now been changed. So the serum requires a value greater than 1. The BAL requires a value greater than 1. Or you can have a combination of a serum greater than 0.7 and a BAL greater than 0.8. The other thing I wanted to mention is the other risk group for invasive aspergillosis outside of our hematological population, solid tumor population, those on immunosuppressants, are patients in the ICU, right, who come in the critically ill population. And the thing we must always remember is that the EORTC MSG criteria was never validated in this patient population. So there is a different criteria that exists for invasive aspergillosis in the ICU. It's called the ASP-ICU criteria, or in fact, I'm blanking on his name. It's actually named after him. I think it's Bolt, but anyways, ASP-ICU criteria. And here, what you're looking for is an aspergillosis positive lower respiratory tract specimen culture, along with compatible signs and symptoms. So now we will accept common things: fever, pleuritic chest pain, dyspnea, hemoptysis, abnormal imaging in the ICU setting, and then the presence of risk factors, and then a semi-quantitative aspergillus positive culture of BAL without bacterial growth. So it must be a sample that does not show bacterial growth. So this particular criteria has shown to be a useful criteria for screening for invasive aspergillosis in the ICU. And it's really become important in the context of the previous influenza. 2 years ago, we had a lot of cases of invasive aspergillosis post-influenza. Now we're seeing invasive aspergillosis post-COVID-19. And if you stick to the EORTC MSG criteria, you're going to miss these cases. You're not going to see them. So I think, recognizing that there is alternative criteria becomes important. Treatment. I'll just walk through this, that there's been a great evolution in the treatment strategies for invasive aspergillosis. In my center, 20 years ago when I started, we used to be here. We used to just treat people with documented infections, and we sat within an empirical world. We now have shifted, and we're very much now a center of prophylaxis and preemptive therapy. So early detection using markers and highly sensitive low-dose CT scans for screening, and certainly prophylaxis for the highest risk group. So that's grade 2 higher GVHD and AML induction, reinduction chemotherapy patients. So there are guidelines. I'm sure you're familiar with them, so I'm not going to go through them, but just to put it up there that there is IDSA practice guidelines for invasive aspergillosis. I think the thing to just highlight is that voriconazole historically was and still remains the, a leading choice for invasive aspergillosis. But we do have, in fact, some new agents that have come along, and I've been involved in a number of these studies along the way. Alternatives certainly include ambisome or amphotericin as a possibility. But let's just talk about the European recommendation. So they've updated it. Not only is voriconazole A1 recommendation, but now isavuconazole as an A1 recommendation, and we certainly have added that to our formulary. I'll briefly discuss the results with you in a short time. And just to mention that combination therapy is not considered first-line therapy at this stage. Now, we have 3 azoles that we're dealing with, and I think you have the same 3 azoles, I believe, in your centers available, voriconazole, posaconazole, and isavuconazole. Just to differentiate these agents very quickly, just on basis of pharmacokinetics, just important to remember that the one big difference amongst them is that this is the only one, isavuconazole, that can be used in people with quite significant renal impairment. And the reason has to do with the this issue of the SBECD stabilizing agent that's used in the IV formulation of voriconazole and posaconazole that can accumulate in people with renal impairment. So that's one defining difference between isavuconazole and the other 2 azoles. I think the other thing to remember is that the hepatic impairment requires really no dose adjustment for posaconazole, but you do still do require dose adjustments for voriconazole and isavuconazole. I'll skip this. There's obviously differences in drug-to-drug interaction issues, and that's been one of the selling points for some of these newer agents. In the case of voriconazole, we worry about 2C9, 2C19 as being the key isoenzymes. In the case of isavuconazole, it's primarily 3A4, which, by the way, is one of the most common isoenzymes for many of our agents. So the drug-to-drug interaction issue hasn't really improved with isavuconazole. And then POSA, on the other hand, is much cleaner from a drug-to-drug interaction issue, with the exception of the drug transport issues of PG protein as being a potential drug interaction issue. So what's the newest comer? The newest comer has been isavuconazole, and I just wanted to briefly overview the isavuconazole trial that's led to the introduction of isavuconazole as first-line therapy in addition to, in case you want to use it in place of voriconazole. So this was a randomized double-blinded placebo-controlled trial of isavuconazole versus voriconazole. Both the FDA and the EMA insisted that the new criteria should be 6-week mortality. So it was powered as a non-inferiority trial, and it met the non-inferiority criteria of 18% mortality at 6 weeks for isavuconazole, 20% for voriconazole. So that really is how voriconazole has moved forward. Isavuconazole has moved forward as an alternative. And certainly in my center, we use it for patients who are either intolerant or have contraindications to voriconazole. It might be drug-to-drug interaction issues, maybe hepatotoxicity concerns, etc. And then the newest paper, which I was co-involved in publishing, is just published in The Lancet, which is the introduction of posaconazole, not for prophylaxis, but posaconazole for treatment. So this is the posaconazole versus voriconazole randomized controlled trial for proven probable invasive aspergillosis. The patient populations are the highest risk group, allogeneic transplants, induction leukemics, and we included liver transplants. That was the high risk group. Everybody else was classified as low risk groups. Patients were randomized to posaconazole standard dosing. We're using the tablet formulation when you switch over, not the suspension. And voriconazole was weight-based dose, 6 mg per kilogram, and then 4 mg per kilogram for maintenance. Because of the FDA's requirement, the primary endpoint was all-cause mortality at 6 weeks, powered as a non-inferiority trial. And again, you see that it met the non-inferiority criteria, 15% in the posaconazole arm, 20% in the voriconazole arm. For those of you that are going to be attending ECMID virtually, you're going to see a second presentation from our group out of this study, which is actually a really interesting PK analysis relating PK data from this trial to both efficacy, but looking at survival and toxicity. So it's actually very, very, very unique and clinical data, which will be really helpful. Secondary endpoints were global clinical response. And so if you look at 6 weeks, again, met the non-inferiority criteria, 44% in the posaconazole arm, 45% in the voriconazole arm. If you took it out to 12 weeks, which is really what used to be our old standard, again, meets the criteria for non-inferiority. So combination therapy, I'll just tell you that there's been lots of interest in combination therapy. Started off with in vitro studies, in vivo studies. Then the first observational study was done by Kieran Marr, looking at voriconazole plus caspofungin. That sort of was a promising study. She sold it as a prospective study, but really was a observational retrospective study. that showed that there may be some role to combination therapy. And then this trial took place, which was the voriconazole plus anadulafungin IA study for proven probable invasive aspergillosis. The primary endpoint was again 6-week survival. It was powered as a superiority trial. And unfortunately, it did not meet it. So it did not meet the superiority criteria was not met. So you have an outcome of, again, 27.8% versus 19%. But for those of you that are familiar with this paper, because now it goes back a couple of years, if you remember, there was a post hoc analysis that was done. And when they looked at the galactomannan positive cases, which frankly made up, we were involved in this as well, made up almost 80 to 85% of the patient populations in both arms, there was a clear benefit for combination therapy. Now, unfortunately, because it was a post hoc analysis, it will never result in this being approved as first-line therapy. Some people may ask, well, if it's post hoc, does it have any meaning? Well, the only reason it has some meaning is that the biological explanation would be that if you have a positive galactomannan, you make an earlier diagnosis. And if you make an earlier diagnosis and you institute earlier effective therapy, you improve outcomes. So there was some biological plausibility, but certainly there will never be another randomized controlled trial, I can tell you, for combination therapy after this. And combination therapy will be reserved for salvage. So thank you. Merci. Shukran. Happy to take any questions.
Thank you very much, Sharik, for this wonderful summary of invasive aspergillosis. And I would like to invite Prof. Nesreen Rizk to comment on this topic. The floor is yours, Prof. Nesreen.
Well, thank you. Thank you, Dr. Haider, for the presentation. Pretty comprehensive. Basically, I don't really have much comments. You covered pretty much everything with the updates, which are the most important. Maybe a few personally, because I've been more invested in or spent a lot of time this year taking care of COVID patients. And what we have been not struggling, but we've witnessed the difficulty in establishing a diagnosis of kappa, or does it really exist? Is this really different from the ICU aspergillosis? Is this really a new entity? What's going on? And I was wondering if you had any comments to share with us, any new insights. And of course, we're aware of the Connelly group also, and the Bassetti, their attempt to establishing some criteria. I'm not sure how. I'd like to hear your thoughts about that first, and then maybe we can have a few minutes. We have less than 5 minutes to discuss kappa.
Okay, excellent. Well, thank you, Dr. Rizk, for that question. And I agree with you. I mean, we're facing the same challenges as I think all of us have learned through COVID-19, that this is a moving dynamic area, and these developments and changes happen, they're on the fly. And so certainly the recognition of aspergillus wasn't, as much a surprise, because 2-3 years before we went through a big influenza outbreak. And so we certainly saw a number of cases of invasive aspergillosis. And so in some ways, the only benefit we had is we sort of extrapolated from that experience. And so what we started doing back then, which we implemented this time, and I think the European folks, and I know Oliver Cornelli well, and we've had many chats, and I think certainly his group would certainly recommend, hasn't yet come from the Americans, this recommendation about routine screening, about this idea of introducing galactomannan screening in the ICUs for your severe and critically ill COVID-19 patients who are ventilator dependent. I think the one thing we have learned, and I actually, I'm sure you do as well, I hold a number of hats here, and I actually manage the COVID ward. So I've seen the spectrum of COVID patients from mild, moderate, severe, critically ill. And I think the one sort of defining feature is that we don't see aspergillus early. We see aspergillus as a late manifestation. So I think that has helped in terms of the epidemiology, is that we're not doing screening in mild to moderate cases. We're only doing it in those on high flow nasal cannula once they're up to about 40 to 50%. And then anybody that goes beyond that to non-invasive and invasive ventilation. So I think the screening, introducing galactomannan screening, I think is useful. And I think certainly, and this is just our limited experience here, I think we're hoping for publications, and you'll see some at ECMID, that the sensitivity is pretty good, actually, for galactomannan screening in this population, because we're not talking about our hematology patients here. They are not patients on azole prophylaxis in any time. So they're clean patients that are walking in. And so the sensitivity for screening has been pretty good. We have also, the other group that we have identified, just to sharing experience, what we have seen in our critically ill patients is that they go one of two ways. They get their dexamethasone and tocilizumab and they settle down, or they get dexamethasone and tocilizumab and then they progress to this thing called COP, cryptogenic organizing pneumonia. Mm-hmm. And it's as they develop cryptogenic organizing pneumonia that you have to worry about this risk of invasive aspergillosis, because often the initial imaging modalities will start to look very much the same. They often end up with a lot of these pleural-based consolidations. And so that's sort of one of our indexes now to say that when we start to see that group, we do early bronchs in those patients and do a BL galactomannan at an early stage and culture, obviously, to try to get to a diagnosis. And as you said, there is a working group from both ERTC, MSG, and certainly the ESCMID group that are looking at trying to come up with a consensus criteria. We have a gentleman here that works at the University of Montreal who's involved in that. So I do believe that we're going to be seeing something relatively soon.
Well, it's interesting that you see that your experience with the sensitivity is good. I had when I last reviewed the topic, I can't remember which study mentioned a lower than 20% sensitivity of the galactomannan in corona or COVID-19 patients who were suspected of having aspergillosis. But that was maybe 6 weeks ago, 7 weeks ago.
Yeah.
Things are moving really
fast. Absolutely. And my only comment, I guess, was going to be that I think it comes down to which groups are you screening. So the problem is that the sensitivity will go down if you screen all comers. But if you screen the highest subgroups, then that sensitivity goes up. And I said, one of the things that we have seen is that this is not a disease that you see early. So I think when I said that the sensitivity is high, is we're not screening everybody. We're screening people based on our influenza experience that we see that are, those guys who are developing that cryptogenic organizing pneumonia, the patients that really have a high propensity for this entity to develop. So I think that maybe, but you're absolutely correct. If you take all comers and you simply do galactomannan screening, no, I think the sensitivity is going to be pretty poor.
Okay, well, certainly, it was it's been challenging here, establishing a diagnosis, and first because of the issues with the galactomannan. Is it? We went through a period of shortage anyway of the reagents. So, and speaking about serum galactomannan, that was even we were suspecting it. But do you and then of course the issue with the BAL and the bronchoscopies, our colleagues were not really very eager to bronching everybody or everybody with COVID, especially a few before we were all vaccinated. And even today, there are, legitimate concerns. So that's the dilemma. But I was just wondering, so do you think that kappa really exists? Or is it the same as the ICU?
Yeah, I think it's a good question. I think it's unclear. I think is the honest answer. I think we don't have enough experience to separate those two entities out. I think it's a great question, and I think the honest answer is I think that's still something that's going to need to be defined as we build the experience and the numbers grow a little bit, and we're able to deal. If you're asking my opinion, I suspect that they're different. And as I said, I think what we're going to start to see with invasive aspergillosis in that ICU, in the COVID population, is that it's a really select subgroup. And that will separate it out, as opposed to, remember that the cases of this criteria, this ASP ICU criteria that was developed, most of those patients we were referring to were people with structural lung disease. So these were your COPD patients walking in. So I think they're really very different. But can we say that for sure at this stage? I think it needs to be defined. And
do you think tocilizumab increases the risk? Have you used it a lot?
We have. You said tocilizumab? I assume maybe 6. So there is an eloquent study being done by, it's a great question you're asking. There's an eloquent study being done by a colleague of ours because, when tocilizumab got introduced, obviously you're all familiar with the recovery trial and so forth. But for those of us that practice transplant infectious diseases or cancer-based infectious diseases, we know that immune dysregulation is a huge issue in that patient population. So you cannot assume that because in a general population with severe COVID-19, you get high IL-6 levels, that you will get the same high IL-6 levels in a post-transplant patient, in a post-hematological AML patient. And so this idea of bringing the same hammer for every patient may actually be harmful. So a study underway by a colleague of mine here at the University of Western Ontario in London, who's doing essentially a cytokine-based analysis, trying to delineate what that cytokine immunological picture looks like in severe COVID patients that are immunocompetent versus those that are transplant patients, AML patients, HIV patients. And I think that really is important before you introduce tocilizumab, because as you said, the concern becomes, is tocilizumab, if anything, does it increase the propensity to some of these other infections from happening? So I think the answer right now is we don't have that signal, but I think it's a legitimate concern. And I think the kind of data that I just spoke about becomes really important. I think we need to understand in some detail what that cytokine picture looks like in a transplant or an AML patient or an HIV patient. And only then should agents like tocilizumab or JAK2 inhibitors or any of these agents be put on for severe COVID.
Okay, well, I think we're over time. I don't know if any of my colleagues have any questions to you.
If I don't mind, you'll just help me for the next talk. I was just wondering, from Saudi Arabia and from Lebanon, I was just curious, just two quick questions. Your available agents for invasive aspergillosis, what do you have available? Do you have all the azoles available? And in terms of your diagnostic algorithms, are you doing routine molecular testing? If you can just take a quick answer to the centers to just help me with the future talks.
So I'll answer for Lebanon. We have, we've had many crises in 1 year, like a lot of crises, and it's a miracle we're still standing, sort of. So we have, but in terms of treatment, voriconazole is available, posaconazole is available on the market, and I think ISA is also registered and may be available. And of course, we run into shortages of the formulations, amphotericin B formulations every once in a while, but so far it's okay. Echinocandins, we seem to be doing okay, I think. Caspo and my center, we use caspofungin is on formulary versus the others, so that's that. Diagnostics, we were barely able to do a galactomannan. It was a send-out test a few weeks ago. It's back to being in-house. We don't perform PCR testing.
Thanks very much.
Culture, of course, when it grows, we have a lab that can still grow it.
Dr. Abir, can you comment on the test and the antifungals that you have in your hospital, King Faisal Specialist Hospital? Abir Shuqairi?
Maybe there is technical problem. Dr. Tariq, you can tell us.
Sorry, I was muted, I guess. Dr. Abir, can you comment on the antifungals and the diagnostic test that you have at King Faisal Specialist Hospital in Jeddah? Dr. Abir Shuqairi?
Well, I am the only one who's supposed to have technical problems or allowed to have technical problems, right?
Okay, Dr. Sarah, now Dr. Sharak, please, can you start your second talk?
Sure. And could you just remind me, is this the mucormycosis one now? Is that what we're on now?
Yes.
Okay. Okay, good evening again. So we're going to jump into this talk on mucormycosis, review the current body of evidence around clinical presentation, medical conditions, sort of geographical presentations, underlying risk groups, and then we'll talk about the current future state of diagnostics in mucormycosis. Mucormycosis, I think you saw on the previous slide, is an emerging pathogen, particularly in centers that have implemented broad azole prophylaxis. But certainly this is a disease that's not limited to cancer patients, as you're well aware. In fact, the largest risk group is outside of that in the form of diabetics. The rarity, however, of this disease prevents clinical trial study and epidemiology and relies a lot often on case series and registry data. And that's one of the sort of challenges, I guess, in mucormycosis. So the diagnosis is challenging and the burden of disease, I think very much so, is likely underestimated. The one thing we are clear about, based on some studies that have been completed, is that earlier diagnosis leads to improved survival. So the importance of earlier diagnostics is critical in mucormycosis. There is sort of two contexts in the developed country world. It's infrequent, but certainly the second most common mold infection in cancer, transplant, and solid organ transplant patients. In the developing world context, it's a disease primarily in patients with uncontrolled diabetes, but increasingly recognized in patients who are with trauma. Put some references, by the way, at the bottom. And I was going to mention to Dr. Kaki and others that I'm happy to send these slides. So not to worry, I'll send these later on. So, you'll have these references if you're interested. Understanding the burden of illness, again, increasing susceptible population. I think there's, again, this understanding that there's a lack of standardized diagnostic strategies. It's very similar. The discussion in mold disease is very similar, whether it's aspergillosis or mucormycosis. So I think the themes are similar. And the other challenge in this particular disease is that there's no harmonized denominators in the literature. So, we're talking about some report cases per 1,000 patient days. Some are population-based studies. Some are based on number of discharges. So I think that makes it all difficult. But I want to, for those of you that are interested, this paper by Jeong and colleagues is really the contemporary update of the literature for mucormycosis. And as you can see here, the highest risk groups are diabetics, of which DKA is the subgroup which increases the propensity for mucormycosis. Certainly hematological malignancies, of which the most common is the AML population. And then within solid organ transplant, the most common visceral transplant is kidneys. And then certainly hematopoietic stem cell transplant around 11%. The distribution of species really depends upon where you are, right? I'll just tell you that in Canada, it's Rhizopus, Mucor, and then Rhizomucor. Those are our top three species that we see here. But obviously, as you can see here, this is global data. And so from a global perspective, top is Rhizopus, and then you see Mucor, and then you see Lichthemia as being the third most common. Some people will throw Epsidia and Lichthemia into the same group. And so again, the reason for this differentiation, the reason for speciation, as you're well aware, is that the susceptibility of some of the treatment agents varies by the specific species that we're talking about. And then probably the most difficult to treat group is Coningamella. The good news is that only about 7%. Again, similar data from Jeong, just highlighting the fact that depending upon the species we're talking about, you can see a variation in the distribution of the disease. So for Rhizopus, you see rhino-orbital cerebral disease as being the most common, followed by pulmonary. If you come to Canada, second most common, which is Mucor, suddenly we see cutaneous disease as being very common, but certainly you see representation of the other two groups. And if I bring you over to Lichthemia, which we certainly are seeing in most countries as sort of the second or third most common, you will see again that cutaneous trauma-related involvement is becoming more and more common. On the other hand, if you do the same thing and break it down just by region, so I sit obviously in North America. So as you can see, I'm in a world of Rhizopus, Mucor, and Rhizomucor. They are seeing some apophysemes, but certainly not where I practice. But in Europe, you are seeing an emergence of Lichthemia. And certainly in Asia, and I guess the Middle East would fall into this, mainly still Rhizopus, but you're seeing Mucor. And I'd love to hear, obviously, in the discussion what you are actually seeing at your own local centers. But you're seeing certainly the issue of Lichthemia emerging as an issue, and then we'll leave the other two out. Pediatric data, this is the publication from BMC Infectious Diseases, and again, just highlighting that the risk groups are very similar, right? Doesn't matter whether it's an adult or a child, hematological malignancy, transplant, diabetics, trauma patients. And again, the distribution, if you're cancer patients, more likely disseminated or pulmonary. If you come down here and you're diabetic, again, small numbers, but we're talking about sino-orbital disease and skin and soft tissue. So I'll skip this. This is not just a disease of numbers. Obviously, there is an impact in terms of costs and morbidity with this. So this is just data out of the MD Anderson group describing over 500 cases from about 47 million inpatient encounters, looking at their burden of hospitalized cases with mucormycosis in the US over 9 years. And as you can see here that diabetics were the largest group, 50%, and then the next most common group was hematological malignancy. So there is a significant, not just necessarily mortality, but a morbidity linked to this disease. I think the association with diabetes, I know I don't need to tell you where you practice because I know it's something you deal with on a day-to-day basis, but without question, it is the single most important driver of the rising burden of mucormycosis outside of the immunocompromised patient population. I think just needs to be said that less than 40% of diabetics worldwide achieve good glycemic control. So I think, that's really the one intervention that would obviously help change the epidemiology. Now, India has a very high burden of mucormycosis, and those numbers have actually grown again just in the context of COVID-19. They've had some secondary cases of mucormycosis after COVID-19, but as you can see here, just under 400 proven cases out of India. And again, 56% of the patients had uncontrollable diabetes. So diabetes remains sort of the single most important sort of global driver for sure. If you looked at your diabetic patients, I think it needs to be said that the disease is primarily rhino-orbital with some CNS involvement. If you come to cancer patients, it's primarily lung disease followed by sinus rhino-orbital CNS involvement, and much less likely to see skin involvement in cancer patients. I just want to remind you the slide I showed you previously just to highlight that this is an emerging pathogen because of this issue of broad azole prophylaxis. So in the transplant cancer patients, it's the introduction of broad azole prophylaxis that has made this, you remember that previous slide, almost, we're saying roughly, 30%, 1/3 of these patients with breakthrough infections had mucorales species. This is a paper that I doubt many of you have read. And the reason I say this is it's probably not a journal that's in your top 7 that you pull out every day. It's called the Journal of Fungi. But I put this up because it's probably the most well-detailed global epidemiology of mucormycosis. So I have no idea why it didn't end up in a much more well-recognized journal. But this is the global distribution of mucormycosis. It's amazing, actually, really wonderful data. I just want to show you Canadian data here. So our rate's about 0.12 per 100,000. So we're actually small players. Compared to, say, some of the European countries, 0.58 per 100,000 in Belgium, and then the list goes on and on. The same paper is a guy named Prakash, so he's broken it down by countries. Just want to show you a couple of these. That in India, again, just by disease state, obviously diabetes and diabetic ketoacidosis being the single most important group. If you come to global data, again, it's diabetes, but followed very closely by hematological malignancy. But I wanted to bring you close to one other one. I just want to share with you. Where did it go? It's right here, Asian data. So here, again, it's interesting because the patient population shifts a little bit and we start to see the impact of sort of trauma and cutaneous cases come up. Similarly, if you did a systematic review of the literature and looked at all key papers and looked at distribution, you would see about the same as what I've said earlier, is that diabetics disproportionately have rhino-orbital cerebral disease, and the trend holds up no matter where you are in the world. I'll skip this. This is just to tell you that you need to know your own local epidemiology because depending upon where you sit, your subspecies will change for sure, right? So we already showed you some of the data, but this is just specific data. And if you get a chance to pull out this paper, you'll probably be able to see some data for at least some Middle Eastern countries that are close to you. Diagnostic challenges. Well, one of the challenges with this is that tissue histopathology and direct microscopy, again, are relatively specific, but they're not routinely performed. And the problem with culture is that it's poorly sensitive. It's slow. It requires expertise for genus and species identification. Like even in my center here, we often don't get species identification. But the importance of knowing whether it's mucor or aspergillus is really important. And the reason that differentiation is that they can start to look similar in terms of risk groups, clinical presentations. But as you well know, the response to treatments are entirely different. And we certainly know that for mucormycosis, delay in effective therapy is associated with negative outcomes. So this was the historical study that had shown that in cases of confirmed invasive mucormycosis, if you delayed amphotericin start for greater than 6 days versus less than 6 days, your mortality climbed from 48% to as high as 80%. It's just making the case that we need to improve our diagnostics. Imaging in mucormycosis. So we talked about the halo sign for invasive aspergillosis. For mucormycosis, these are sort of, again, I would say they're certainly not sensitive. They're somewhat specific, but they may be helpful in the right context. So if you see multiple nodules greater than 10, think about mucormycosis. If you see large effusions, it's very uncommon to see that with aspergillus, but you'll see that with mucormycosis. For CNS disease, the vessel occlusion sign, and then this description of what's called the reverse halo sign, which again, in the right context, can be seen with mucormycosis. Imaging studies, again, MRI or CT is the way to go if you're thinking about rhino-orbital cerebral disease. But I think there's a lack of specificity. Again, that's the key point to mention for any of these things, whether it's imaging studies and so forth, and clinical presentations. And so the need to improve diagnostics is critical. This is just, by the way, for those, I'm sure most of you know, but for those that, in case there's some junior staff on, a reverse halo sign is just the opposite. So instead of seeing that zone of infarction surrounded by a rim of hemorrhage, you see essentially a hypoattenuating area surrounded by a rim of hyperattenuation, the reverse halo sign. Okay. So histopathology is the reference standard for microbiological diagnosis for mucormycosis. You can use fresh or formalin paraffin embedded tissue. What you're looking for is these broad asepted ribbon-like hyphae with irregular branching. It is still an imperfect science, and the morphology can be mistaken for aspergillus, and therefore confirmation by culture or molecular method is still necessary. And so the issue with culture, again, I mentioned that even in my center, we often don't get to the species level, but it is important to try to get to that level, both for your own local epidemiology and certainly when it comes to response to treatment, because there's a variation that exists there. But just remember that up to 50% of histopathological specimens will be culture negative. The other key thing to remember about the culture piece is that if you grind your tissue, that impacts the viability of the hyphae. And so just from a processing perspective and a sensitivity perspective, something to keep in mind. The good news is these are rapid growers. So if you are lucky enough to grow this thing out, 3 to 7 days, and you'll be able to see it. Where is the future? The future is molecular, just like you heard for invasive aspergillosis. The area that I'm just in the interest of time, I'm just going to cut through this and tell you that we have looked at 2 major areas, obviously for molecular testing. One is the internal transcriber ITS, which probably is the area most often cited. And then there are rRNA locuses that have been used, including the 28S RNA subunit. Generally, that's done if the ITS is not proven to be helpful. And as you see here, the internal transcribe spacer has become the universal DNA barcode marker for fungi. It's the highest probability of successful identification for the broadest range of fungi. Again, I can tell you in my center, this is not a routinely available test. It's still very much a research-based test. So I'm just going to skip this in the interest of time and talk about quantitative PCR detection. So this is a retrospective study from the French experience looking at patient serum from proven and probable mucormycosis patients, a mix of diabetics, but mainly hematological patients. 17 had pulmonary disease, 14 disseminated, 8 rhinocerebral. And the assay picked up rhizomucor, rhizopus/mucor, and leukemia. The quantitative PCR was 81% sensitive. And again, the importance of PCR is that the first positive serum was median 9 days earlier than the first mycological sign in 36 patients. So obviously, this is the way. We just said to you that there is that wonderful study showing you that if you don't start appropriate treatment within 6 days, your mortality signal climbs to as high as 80%. How do we get there? It's molecular testing. Molecular testing will improve that timeline and that sensitivity to get you there. Quantitative PCRs can also, I just wanted to mention, be used as for monitoring response to antifungal therapy, but highly sensitive in high-risk patients, as high as 90%. Just going to skip that, just in the interest of time, because I'll send you these slides later. I think, again, the quantitative PCR will certainly be an important tool, particularly when we start talking about pulmonary disease, and has been very useful, again, not both just in diagnosis, but again, for response to treatment, has been a very useful entity. Why is it that the current culture-based and automated methods may not be ideal? But one of the reasons, just as if you look at MALDI-TOF, the Bruker library sometimes doesn't have an appropriate representation of all the less common species of mucormycosis that is seen, and hence some of the limitations. The other very important thing to remember is that I'll have to ask you that in your comments or discussion session, whether you use UCAST or CLSI in terms of your susceptibility testing and cutoffs. But the only clinical breakpoint that's available, just always to remember, for any mold was really for Aspergillus fumigatus and voriconazole. So I think that's again one of the challenges when we're talking about mold disease. So summary, epidemiological data supports mucormycosis as a rare invasive fungal disease with specific risk groups being diabetics and the rising burden of diabetes, certainly hematological patient populations. Clinical diagnostic practices are likely underrepresenting the true epidemiology because you've seen that the sensitivity, where the histopathology has challenges, culture has challenges, and therefore, obviously, there's a need to continue to expand new diagnostic modalities, particularly the molecular world. The ITS target looks really promising. And here it becomes really important because there is, in fact, a clear mortality signal if you delay effective therapy. So just in the interest of time, I'm actually going to stop there and perhaps open it up for questions. I had a case, but I'm sensitive to your time limitation. So I'll perhaps open it up for questions. If you want me to go through the case, I can go through it, but I just respecting time.
Yes. Thank you so much, Dr. Sharik. Yes, Prof. Tariq?
Yeah, go ahead, Prof. Maisa.
Now, Professor Dr. Ahmed Saad, please, your comment.
Thank you so much for this excellent presentation, excellent data. We cannot speak to nowadays for any issues without mentioning the COVID patients.
Yeah.
There is already there is a big study on the mucormycosis from India, an Indian Journal of Ophthalmology on 2,860, one of the huge studies all over the world since history of mucormycosis. It was a huge study mentioning a lot of data for the mucor, which is very important to all of us. They found males almost 70%, like many other series, that males are more common in mucor. I don't know why, if you can tell me. Diabetics was 80%, the cases as risk factor, hypertension 12%. The incidence of the mucormycosis in COVID cases was between 10 and 15 days in 60% of cases. The mortality was strangely low. The mortality was only 14% mortality of mucormycosis, and they divided the cases, as you said, as possible and probable and proven with the microbiology and the histology. One of the very important early signs for all of us to know, because they detected that cases early, of the orbital facial pain in 25%, orbital facial edema in 20%, and the signs also of orbital ocular edema and sometimes loss of vision. They found the steroids not different between DEXA and the methylprednisolone. They are both almost the same. Tocilizumab was not associated with mucor by any means, their data, for that huge number of cases. Also, remdesivir was not associated with mucor. Against all the guidelines, they used the combination therapy in almost 650 cases. 25% of the serious, they used either amphotericin B. I want to ask your opinion for using that combination of ampho B, liposomal amphotericin plus fluconazole, or liposomal amphotericin plus isafo. They used also intraorbital liposomal amphotericin in 22% of cases. The first question for you, when to use the combination, because they used that almost 1/4 of cases they use combination therapy. This is the first question for you.
Right. No, first of all, thank you for sharing that and for sharing with everybody on the line. And as you highlighted, India is going through a significant COVID-19 explosion and challenge. And obviously, one of the challenges in India is that it's two diseases that are intersecting. They have a high burden of COVID-19, and then they have, unfortunately, a very high burden, as you know, of diabetes in that patient population. So it's unfortunately the perfect sort of milieu and setup for us to be seeing breakthrough mucormycosis happening. I had actually, and I will forward these slides to you, as many of you are aware on the line, there has been an update of mucormycosis guidelines by Oliver Cornelli's group. And I had some slides on to it in the interest of time. But based on those consensus recommendations, and certainly our own experience here, there really is no real reason for you as a routine to be adding posaconazole and ambisome for all cases of confirmed, proven or probable mucormycosis, with one exception. And the exception might be, it goes back to that global distribution I was talking about in terms of the species of mucormycosis you're talking about. So India, perhaps, and I wouldn't be surprised, in fact, I think I'm correct on this, has a high proportion of Kiningamella. And Kiningamella has this issue of, as you know, broad azole resistance concerns that have come up. And so certainly the idea of combination therapy, if you're dealing with, shall we say, fairly resistant subspecies of mucormycosis, would make sense. But should it be done as a routine intervention? The answer is no. But to answer your question, has there been a randomized controlled trial that has looked at combination versus monotherapy for invasive mucormycosis? The answer is no. We actually don't. We don't actually have that data. We have in vitro data. We have in vivo data. We have observational retrospective experience that suggests that combination therapy is not necessary. There's obviously some cost implications related to the use of double agents. So I can't speak as to why they did it in India, but the only explanation I could give that would be sort of a scientific explanation would be that perhaps, again, the species that they're dealing with, because they do see a lot of non-rhizopus, non-rhizomucor, they start to see a lot of apophysemes, certainly Kiningamella, then yes, in that context, throwing on this while you're waiting for your susceptibility testing to come back, I think is probably not unreasonable.
The second question also regarding the some of the transplant centers as using caspofungin add-on to liposomal amphotericin. You have any data of adding echinocandins to the liposomal amphotericin in mucor? Because few articles about using this. Do you have an?
Yeah, yeah, absolutely. Thanks for bringing that up. There's a lot of interest, as you know, in echinocandins in general, because we always look at the echinocandins as drugs with wide therapeutic indexes, right? They're once daily drugs, in most cases, easily tolerated, minimal side effects. So there's a big push to use these agents. And so, as you know, there is in vitro data for echinocandin activity against mucormycosis, but the clinical trials that have been completed, and they're limited, but the limited clinical data that we have suggests that there really is not a huge benefit of echinocandins, certainly as monotherapy. Now, echinocandins in combination with amphotericin or liposomal amphotericin, I think it comes back to exactly what I said earlier. It depends upon what species of mucormycosis you're talking about. Depending upon that context, I suspect that's why there has been such you're seeing a lot of emergence of this data, is that as we get into specifically Kiningamella as an example, yes, there is certainly some in vitro data about the use of ambisome polyenes in combination with echinocandins showing good in vitro activity. So I think in the right context, it makes sense. I think the only message I wanted to highlight is that certainly echinocandins should never be first line for mucormycosis. They certainly should not be used as monotherapy, and certainly combination therapy for all comers is not indicated. And if you obviously go to the most recently updated global consensus guidelines that they have released, there is really no recommendation for combination therapy.
In that huge number of cases in India, they found also the same data as you mentioned. Culture was only positive in 50% of cases. Let's say 50% can be negative culture. So the histopathology and frozen sections, it helped them a lot. And also, they start to use multi-dose also, as you said, in diagnosis. There is another issue of you mentioned already that the pressure of using voriconazole in transplant patients increased the incidence of another fungi like the mucor or fusarium. Two big studies, one of them, the Transnet study on 400 multi-center trial, showed that using the voriconazole as prophylaxis, it can increase the pressure for the mucor and fusarium. Also, another trial, single-center study on the using of the voriconazole prophylaxis also for transplant, showing higher incidence of mucor. What is the explanation for that?
So this is actually not necessarily new data. As you know, this data is quite historical data, because if you remember, as soon as voriconazole got its approval, in many of the larger tertiary centers in both Europe, America, certainly the classic example, the classic paper is a paper from Kieran Marr way back, almost goes back now over 10 years ago, where they started implementing voriconazole prophylaxis in their both their induction leukemics and certainly in their allotransplant populations, and very early were able to show that there was in fact a selection pressure. So the answer as to why, well, I think this is something we've always known as infectious disease physicians, right? That we have always been wary about introducing prophylactic strategies, because every time we have done it, we have always seen this selection pressure issue that has come up. So I think the answer is pretty clear that it's not unexpected. I think that, whenever you introduce prophylaxis, you introduce prophylaxis. The only time prophylaxis should be appropriate is you need, in my opinion, you need two criteria to be met. One is that it needs to be a drug that has a wide therapeutic index, because you're giving it to people who don't have the disease, right? So it should be a drug that's well tolerated, that's easy to monitor, and minimal side effects. And the second thing that you need before you implement prophylaxis in your centers is you need to understand what your true burden of disease is. You can't take a clinical trial paper and implement that in your center, because unless your burden of disease is the same as what they're seeing in that clinical trial, that data doesn't actually hold up. And the third thing is that you need to have an acceptable breakthrough rate. So this is what I was referencing in the aspergillus talk that I gave you, that we now have a plethora of I'll call it phase 4 real life data experiences from a spectrum of centers across the world that have shown that the breakthrough rate for posaconazole prophylaxis in AML is only 2%. Because if the rate was as high as 10%, then there is really no rationale to doing azole prophylaxis, because you're just trading off one disease for another, right? And potentially actually creating a much more difficult disease to treat down the road. Because if you saw the organisms that people break through with, it tends to be certainly much more resistant molds that you're getting, right? It's those dematiations. You mentioned Fusarium, Scedosporium, Alternaria. We're seeing all of that in people on broad azole prophylaxis. So to answer your question, Dr. Saad, I think the why is this is the mycology, this is the bacteriology that we've always known, is that organisms will evolve under selection pressure. And so it is certainly always been recognized. And that's why, I'll give you an example. In my center, that Cornelli paper was published in 2007. We only implemented posaconazole prophylaxis 2.5 years ago, not because we didn't know the data, because we were waiting for two things. One was we were waiting for our own local epidemiological data. And two, we were waiting for the phase 4 data to see what does this look like in real life experience. Do you match that 2% breakthrough rate? Because our concern was that we may see a much higher rate in real life. But in fact, in the clinical trials, the phase 4 data looks very promising. So anyways, I'm not sure I completely answered your question, but yes, thank you for highlighting that. Absolutely, that is a concern.
Thank you so much. Thank you so much.
May I just ask Sharik, how would you treat mucormycosis initially? Most of us use amphotericin B, and then once patients have improved, they switch to, say, isavuconazole or maybe posaconazole. So how do you normally treat mucor, and for how long? When would you stop the antifungals?
I wish I could share this case with you, because you would start laughing if you'd seen it, because then you would get the answer to your question. So this was a really challenging case that went out to this person was on treatment for over 1.5 to 2 years. And then eventually said, I've had it. I don't want to see you anymore. And that was it. And then 3 months later, the patient came back and had mucormycosis in a new site, had renal mucormycosis. So you're asking a great question. It's the duration of therapy is exceptionally challenging in mucormycosis. And I would say probably somewhat easier in pulmonary disease to some extent, because, serial imagings can be used. You can use, as I mentioned, quantitative PCRs if you have available for assessment of response to treatment. When it comes to rhino-orbital cerebral disease, it's really challenging, right? Because you get these follow-up MRIs where you're still questioning whether or not there is some residual disease that's left over. And so, I think, guidelines, if you notice, guidelines are very good at telling you what to start. Guidelines are very poor in telling you when to stop. And the reason is that there is all kinds of patient-specific factors that we all look at to make that decision, right? And the most important one being, where are they in their immune cascade, right? Where are they in their immune reconstitution? Because that's going to be the single most important determining factor, in addition to clinical symptoms, signs, radiological imaging. In terms of what we do here locally, we do exactly what you do. We initiate always with ambisome because, as you know, there is initially a delay in getting. So usually we get a histopathology sample back that shows, non-septated hyphae. We know we're dealing with mucormycosis. We start with ambisome, and we start at full doses. So we don't do the 3 or 5. We go straight to 10 mg per kilogram, and then we de-escalate. Now, if you look at the guidelines that Corneli has put out, his recommendation, he's got these sort of categories of strongly recommended and moderately recommended, and the strong recommendation still is ambisome. The moderate recommendation first line is the other 2 azoles, either posaconazole or isavuconazole. But I just want to tell you, because I was actually involved in all the trials for posa and isavuconazole, that it's interesting to me, and I wrote actually to him for a comment on that, because I was surprised that posaconazole and isavuconazole got put on the same bar. And the reason I mention is the following. Posaconazole, there's actually not been a dedicated posaconazole mucormycosis study that was done for registry. The posaconazole experience was actually a study for refractory mold infection, whereas isavuconazole, as you're well aware, went through a historical control study, where in fact it was studied specifically for mucormycosis. And so, he's put both of them as equivalent agents. I just find it interesting because I would say that the clinical trial experience is not similar in those. I actually think there is a difference. So certainly here, it used to be that we would go from ambisome to posa pretty quickly. Now that we have isavuconazole available, we tend to go from ambisome to isavuconazole, assuming that we're not dealing surprisingly with a Kiningamella species or so forth. Then obviously that would change things, but for most comers.
In that big study published from India, they used liposomal amphotericin in the range of 5 milligram. If there is cerebral, they used 10 milligram for 4 weeks after clinical improvement. 4 weeks liposomal amphotericin. After that, they de-escalate to either PUSA or Ozavu for 3 to 6 months, according to the clinical response in that huge number of patients.
Absolutely, and I think that's typically the median response time. I mean, as you know, in the clinical trials, for aspergillus, they're looking at 6 weeks. If you look at clinical trials for mucormycosis, I mean, any earlier than 12 weeks would make no sense, because this disease does take a while before you see clinical response. So certainly 3 to 6 months is where you are. But as I said, if I had shown you that case, you would have thought, oh my Lord, this was just going on for 1.5 years to 2 years. And we actually presented this at the ECMID 3 years ago, this case. So it's a challenging disease for sure. No question.
Prof. Maisa, may I just ask Dr. Abir? She's back with us, I think, because she got called for an emergency, and now she's back.
Yes.
May I ask her the question that Sharik asked? Which antifungals you have in your hospital, Dr. Abir? And what are the diagnostic tests you use for invasive aspergillosis?
Thank you, Prof. So questions Frida mentioned most of the difficulties we're all suffering when it comes to the diagnostics. So basically, we have the serum galactomannan and the galactomannan in the BL, but as Prof. Haidat has correctly mentioned, the problem with our high-risk population is doing the BL in hematological patients, malignancies, low platelets, they are critically ill on high oxygen, and then most of the pulmonary ICU services, they are reluctant to do a bronchoscopy for these type of patients. So unfortunately, at this point in time, I'm again, I like your slide about the challenges of the diagnostics. So probably, to tell you the truth, I would still say that we are going more with the diagnosis of hosts, like being a host with the high risk for invasive aspergillosis, plus the imaging study. And then if we're lucky with the serum, and then at what point if we do the BL, then we will be faced with the high galactomannan. Your point about the fact about the role of prophylaxis in reducing the yield of galactomannan detection in cultures is really interesting, because I think this is again one of the most of our population are currently on posaconazole prophylaxis, as you correctly mentioned, the leukemias, the bone marrow transplant. And this again will complicate the diagnosis or the confirmation of aspergillosis further. Regarding the availability of the medication, we have the liposomal amphotericin and we have the VORI. Unfortunately, we don't have the ISO now. But I would be also interested to hear your feedback and experience. Like at this point in time, we're still, using between the liposomal and the voriconazole based on the suspicions of aspergillosis versus mucor. And of course, we have only the oral formulation. We don't have the IV. So we've been using it for the prophylaxis for the high-risk population. But I'm interested, like, in terms to the center-based experience, like, is the availability of ISO have made you change your somehow practice? You're using it more than the liposomal amphotericin B versus the rest of the azoles. And of course, as you correctly mentioned, the drug interaction is really a major consideration with the use of azoles. We're faced with patients where they have hepatotoxicity, graft versus host disease. We cannot use azole, and they need to be on prophylaxis for antifungal. So these are the high-risk population. We don't have really a good prophylaxis to give them. So this is the challenges I'm just summarizing the challenges that we tend to face in our patient population. And of course, we have the echinocandids, the caspofungin, and the anidulafungin. But as you correctly mentioned, we never use them for invasive aspergillosis. Rarely we use a combination with liposomal amphotericin in refractory or difficult to treat patients.
Okay, thank you for sharing the experience. The quick answer to your question about asabuconazole. So yes, since the agent got approved and became available in our center, we have certainly seen an uptake, and for all the right reasons. I think, remember, the biggest challenge, I'm sure all of you are very experienced, will agree, that we have learned to work with a very challenging drug called voriconazole. We all know that voriconazole has unpredictable intra and inter individual variability in PK. You have no idea what level of voriconazole you're sitting at. And the reality is that therapeutic drug monitoring with voriconazole is highly recommended. It's often not routinely done, and often it's not even routinely available at many centers. So we've always known that we've been sitting with a drug where, I hate to use the expression, but we put our head in the sands and hope that things are going well. But the reality is it's got truly unpredictable kinetics. So it was very easy when this randomized control trial data came out showing at least equivalence. In fact, there is actually a slight, it's a numerical benefit for isavuconazole in terms of 6-week survival. It was 84% in the isavuconazole arm. So it actually exceeded voriconazole, but just didn't reach the defined cutoff for superiority. So we think for all those reasons, this is a safer drug, a much more predictable drug in terms of not requiring routine therapeutic monitoring. And then the third issue that I know you're all going to agree is that most of these high-risk patients are on a number of agents with QT prolongation. And one of the other very important aspects of isavuconazole is the only azole around that does not cause QT prolongation. In fact, as you're aware, it actually shortens your QT. So the only people that you cannot use it in are those rare people that actually have short QT syndrome as a diagnosis, which is uncommon, but is described. So for all those reasons, the uptake for isavuconazole has been very good. I think, our sense is that we'll replace voriconazole for invasive aspergillosis very soon once the cost issues start to taper down a bit. It certainly will replace ambisome. A lot of you are young, and some of you are a bit more senior than I am. But for those of us that have been around for a while, it's amazing watching the journey of amphotericin. When I was at my early stages of training and early practice, we used ambisome all the time, and we saw renal impairment, and we worked around it. It was no big deal. You saw a little bit of renal impairment, you pushed the fluids, you kept going. Now, you put someone on ambisome, and within about 36 hours, I can be guaranteed that I'm going to get a phone call to tell me that the creatinine went up, from 108 to 126, and when can we pull the ambisome? So the threshold to tolerate or to work with ambisome has really dropped, and it's a shame because the fact is it still remains our most effective drug when it comes to, when you think about in vitro coverage, in terms of resistance concerns. In terms of predictable kinetics, the only issue with it has been tolerability around infusions and renal toxicity. But the hematologists, at least in our centers, and I suspect it's the same in many of your centers, their ability these days to tolerate ambisome is very low. The minute they go on it, you get calls to say, when are we pulling them off the ambisome? When can we de-escalate? So certainly ambisome use has gone significantly down. And I anticipate that savuconazole use will continue to go up for invasive aspergillosis and certainly for step-down therapy for mucormycosis.
Okay, thank you so much, Dr. Ahmed Saad, Dr. Abir, Dr. Tariq, and please, Dr. Sharik, can we move to the third part of our meeting?
Sure. All right, well, good evening. I'm sure you're getting tired of listening to me here this evening, but I promise you this is the last, this is the last talk. So this is on invasive candidiasis and candidemia developments, and I've introduced some little nuances, which I think hopefully there'll be some information that will be new to you on this talk, because you are a very experienced group of consultants. So a little bit about the epidemiology of invasive candidiasis and candidemia, but then I want to focus on a little bit around breach of immunity and the risk of invasive candidiasis and how we have these new emerging risk groups for invasive candidiasis that we now need to be aware of. And then obviously developments around treatment. So I'll start off with a case. This is a 37-year-old female involved in a motor vehicle accident, multiple traumatic injuries, closed head, pelvic fracture, ruptured spleen. She underwent a laparotomy for a splenectomy, got the usual vaccines given to her before the splenectomy. Postoperatively was transferred to the SICU, intubated, had a central subclavian central line, a radial artery art line put in, and a urinary catheter, had a prolonged SIU stay as would be anticipated. The patient is not given antifungal prophylaxis. On post-op day 3, she develops a new infiltrate, a fever of 39 degrees, and a white count with left shift. At that time in the center, the treatment for these types of, we'll call it hospital-acquired pneumonias, where combination therapy, we don't routinely do this now, with piperacillin, tazobactam plus gentamicin. And on post-op day 8, despite the effective antibiotics, the fever recurs at 38.8. Cultures and septic workup is sent back. The chest X-ray actually shows that there has been improvement, even though it's only been 8 days. So that's good news. The urine microscopy reveals rare white cells, but does show many yeast. The sputum culture also shows yeast. Blood cultures are pending. It's day 9. The fever persists. The exam is unchanged. And then the patient has not begun antifungal therapy. And on day 10, the patient becomes hypotensive, low urine output. And the microlab calls to say that the blood cultures are now growing yeast. So I won't make you answer this, but assuming that no prophylactic or empirical antifungal therapy has been started in this ICU patient, what regimen would you start? And the answer to that is it'll depend. The quick answer is depend where you are. In Lebanon, it'll be a different answer. In Canada, it'll be a different answer. In Saudi Arabia, it'll be a different answer, because it'll come down to what is your epidemiology of species, proportion of Canada albicans to non-albicans Canada. That will guide that, right? Because depending on what proportion of non-albicans Canada you have, you're going to use an induction de-escalation strategy. So certainly in our center, we tend to do an induction de-escalation strategy. And then I just asked that question, would you have now in hindsight considered starting this patient on prophylaxis? Remember, this patient was not on prophylaxis. So I'd love to hear in your discussions what you're doing in Saudi Arabia and in Lebanon and Egypt in terms of prophylaxing for Canada in the ICUs. Not in your hematology patients, just in your general ICU patients, surgical patients. So epidemiology, as you well know, it is a nosocomial cause of bloodstream infections. In fact, it's starting to become, we say certainly based on Canadian data and North American data, it's the 4th leading cause of nosocomial bloodstream infections. It accounts for 80% of all major systemic fungal infections, so it's much more common than mold infections. The crude mortality is at least 40%, and the attributable mortality is 25%. And based on historical cohort studies, the access days of hospitalization averages 12 days. So there certainly is, certainly morbidity and cost implications, not just mortality linked to this disease. If you look at Canada, just to show you our shifting epidemiology for candidiasis and candidemia in Canada, if you go to the paper, this table on the right, you're going to see that in 1999, we had 70% of the isolates in Canada were friendly Candida albicans. Only 10% were Parapsilosis, 8% glabrata. When the study was repeated in late 90s, early 2002, suddenly now we have dropped from 70% to only 55% being C. albicans. And now what took up that difference? A rise in C. glabrata, at least 14%. The rate of C. krusei also went up from 1% to 4.3%. And as you know, this is important because with krusei, we deal with agents that are fully resistant to azoles. With parapsilosis, we deal with with glabratas, we generally deal with the issue of dose-dependent susceptibility, though there are fully resistant strains of glabrata that can be to fluconazole, but certainly dose-dependent susceptibility is the biggest issue. So that's an example of shifting epidemiology, and I'm sure your description is going to be different in Lebanon and Egypt and Saudi Arabia, but the messaging here is you need to know. You need to know what your local mycology is because it has not remained the same. That was sure of. No matter where you are in the world, there's been a shifting epidemiology. Just share a paper that we were involved with that just shares some, and I put this up not because it's Canadian data, but just to highlight, the paper will highlight some of the general messages around candidiasis and candidemia. So it's called the Prospective Antifungal Therapy Alliance, the PATH study. It was published, it involved over 6,500 patients, nearly 7,000 proven and probable invasive fungal infections. The reason I really like this registry is that this registry, though it started off in the lab because you had to have a positive culture to start things off with, it is exceptionally rich in its clinical data. So there is a plethora of clinical experience linked to these positive culture results. The main paper, which is published, called the PATH Alliance. And then what we did, because there were 2 Canadian centers, I was one of them, we did a separate Canadian study as well, just to pull out the 2-center Canadian experience. But I just want to share with you the Canadian data. I just tell you, who do you see candidiasis and candidemia in? Well, first of all, just to remember that these classifications are not mutually exclusive. So patients could end up in more than one category. But when it came to the investigators, general medicine made up 76%, cancer patients only 16%, and then you come down to solid tumor 15%, and surgical non-transplant a third. So medicine and surgery obviously are common areas. This is not unlike the mold discussion. This is not a disease that's exclusive to cancer transplant centers. I think you all know that. What about the types of organisms? So look what happened in this study. The PATH Alliance is much more recent than even the 2002 data. Now we went from 70% Candida albicans to only 40% Candida albicans. And the emergence, again, of Candida glabrata as high as 19%, parapsilosis is about 10%, and Krusei is still sitting around 4 to 5%. So again, really knowing your local epidemiology is really important. The data, if you haven't read the full PATH Alliance paper, it's worth a read because it's really rich in the clinical experience. It shows everything from the clinical presentation, clinical outcomes, survival data, types of diagnostics that were used. But just to show you that the survival curves for invasive aspergillosis and for invasive candidiasis, the top actually is the candidemia one. So at 3 months, we're talking about a 66% survival rate for confirmed cases of invasive candidiasis and candidemia that was seen. What are the major risk factors? I think we all know these: cancer, chemotherapy, neutropenia, colonization. I'm going to come back to this because it starts with colonization, right? Broad spectrum antibiotics, central lines, hemodialysis, severity of illness, malnutrition, and obviously the flip side being the need for parenteral nutrition, mechanical ventilation, and diabetes again shows up, right, as an important risk factor. So I'm going to use this graph just to address the issue of how eloquent the immune system is in ensuring that we don't go from colonization to infection, because as we all know, we are all colonized with Candida in our, certainly in our GI-GU tracts, in our oropharyngeal tracts, certainly even in our axilla. So what prevents you from going from Candida colonization to infection? And it's amazing just to kind of walk through this, because I always find this such an eloquent immune response, and then how a breakdown of this immune response will translate into the risk of invasive candidiasis. So here's this colonization taking place. And the first thing that happens is that if you pass through that epithelial layer, the innate immune system kicks in. You have local tissue macrophages, and those local tissue macrophages produce IL-12, IL-18. The response to IL-12, IL-18 is to activate T lymphocytes and differentiate those T lymphocytes into a subset called Th17. Th17 then produces IL-17 and IL-22, and these two cytokines produce a peptide called beta-defensin. And beta-defensin is one of the most important peptides to protect us against Candida propagation, Candida invasion. So if I do something to block IL-17 or I do something to block IL-22, I substantially increase my risk of invasive candidiasis, right? So the point being made is that not only do you have an eloquent innate immune response, you have an eloquent adaptive immune response. And what starts this all off? Well, what starts this off is that we all know now in bacteriology and in mycology that we have these things called pattern recognition molecules, right? That every organism has a footprint or a fingerprint. So we have pattern recognition receptors that recognize these pattern recognition molecules. For Candida, it's the cell wall components. It's the chitin, the mannan proteins. Those are the major pattern recognition molecules that are recognized by pattern recognition receptors. As soon as that recognition takes place, these tissue macrophages are activated and the cycle starts. And so again, just the importance of understanding this innate immune response is that every time we disrupt a component of this, if I have a problem with chronic granulomatous disease and I have a problem with superoxide anion production, I will increase my risk of invasive candidiasis, because one of the effects of tissue macrophages is that they actually, by releasing IL-12, IL-18, and TNF-alpha, they recruit neutrophils. If I compromise my neutrophil function or response, I increase my risk of invasive candidiasis. So there are a number of, other than the classical risk factors, there are inheritable conditions, these things called single nucleotide polymorphisms, SNPs, that increase your risk of candidiasis. Remember I said the major pattern recognition molecule for Candida was mannans, which are present in your cell wall. So if you have an SNP that affects the mannan binding lectin, you increase your risk of invasive candidiasis. One of the major pattern recognition receptors is TLR. So people that have SNPs in SNPs affecting toll-like receptors are at higher risk of candidemia. How about if we go to primary immunodeficiency states? So remember Th17, I mentioned those subsets of CD4 cells. If you have a defect in Th17 immunity, and there are conditions such as CARD9, STAT3 deficiency, I'm going to share a case with you very soon, you increase your risk of chronic mucocutaneous candidiasis by 80%. So though we always think about the classical risk groups, right? Antibiotics, indwelling catheters, neutropenia, right? All those things, we have to be aware that there's this intricate immune response, that any breakdown in any of these intricate innate immune responses or adaptive immune responses will translate into invasive candidiasis. So here's an example. I don't know how many of you are aware of this, because how commonly you see these patients, but there's been an explosion in the dermatology world with the use of these anti-IL-17 agents. The secukinumab, bimekizumab, brodalumab. When you block IL-17, remember IL-17 was really important for the production of beta defensins. Beta defensins were the key peptide to prevent propagation of Candida. So guess what's happened? Though these agents are amazing against severe psoriasis, because IL-17 is blocked, because IL-17 mediates keratinocyte proliferation. So it's great for psoriasis. But what they've been seeing in the clinical trials is an explosion of chronic mucocutaneous candidiasis. So just to see how the risk groups for invasive candidiasis and candidemia is changing as we expand these immunological agents. So I want to share a case with you. So this is a case of mine, a 52-year-old woman with relapsing recurrent mucocutaneous candidiasis. She has a dermatological diagnosis called the acrodermatitis of Halipo, and she is on Cosentyx. Cosentyx is essentially secukinumab. She also happens to have IgG3 subclass deficiency and is on GCSF, sub-Q GCSF. She has Lynch syndrome, which is associated, as you know, with inheritable malignancies. She happens to be a carrier for the CF mutation as bronchiectasis and recurrent pneumonias on BiPAP. And her story is that she was referred to me because of recurrent mucocutaneous candidiasis, thrush, axilla, breast, and groin. And remember, she has been on this anti-IL-17 agent since 2016 with these recurrent bouts. This is just pictures from her. Cutaneous, this is on the breast, just underneath the knee. She has extensive and even vulvar candidiasis, really, really disabling. So one of the challenges was that because of her other conditions, she's also on a pain medication called Metadol. And we were unable to prescribe any oral azoles because the azoles, because of the CYP3A4 interaction, would increase her pain medication. If you increase the pain medication, the effect is that it'll affect her respiratory drive. Remember, she was on BiPAP. So we had to come up with an alternative. So we treated her with caspofungin for 5 months with complete clearance. She was the happiest woman I've ever seen. And then we spoke to our dermatologist and said, listen, this will keep happening unless we make a decision to look at an alternative agent. And so eventually she was switched from an anti-IL-17 agent to an anti-IL-23 agent, and we haven't seen a relapse of her candidiasis. So just to highlight these sort of new risk groups that you don't typically think about for invasive candidiasis and candidemia. Diagnostics. Now, the good news is, thank God the discussion for molds is over, because we can finally say culture works. So culture is useful for yeast, as you know. It has improved sensitivity. The microbiologists will always say in the automated blood culture world that it's 100% sensitive. I still think that we do see cases of invasive candidiasis and candidemia in the ICUs, which are culture negative, that come up. But certainly with automated blood culture methods, things have improved. But are there alternatives? The answer is yes. So the other test that is available, as you know, is the beta-1,3 glucan assay, which certainly is a highly sensitive assay for invasive candidiasis. And so specificity is 99%. So really a useful test if your beta-1,3 beta-1,3 glucan assay is negative, you can confidently exclude the possibility of invasive candidiasis and candidemia. Just going to skip one little thing here. I'm going to skip this and just switch over to management of invasive candidiasis and candidemia. So I think you all know that we've talked about it briefly in the discussions. We're dealing with azoles, we're dealing with echinocandins, and obviously we're dealing with the polyenes, right? That really is our current available sort of algorithm. The only agents we hadn't discussed was 5-FC. So this is just in Canada. This is how the drugs came along. Right, in Canada, we had flucytosine as the first drug, and then early 1990s, Itra, keto. Then we got Abelset, then we got liposomal amphotericin, then we got caspofungin, voriconazole, micafungin, posa, anadulafungin, and I should add a number that we now have, isavuconazole. It's been certainly there's been an expansion of agents for sure. So when you're picking an antifungal agent for invasive candidiasis, candidemia, you must know your local epidemiology. That's critical. That's the starting point. And that affects the susceptibility of your candida isolates. You should obviously look at the issue of pharmacokinetics and pharmacodynamics, tolerability, and efficacy. So just to summarize, candidemia trials in non-neutropenic patients. These are the key papers that are out there, and this is kind of what led to the azoles being positioned right as a potential therapeutic option. So this is I'll just take you to the Kohlberg paper. This is actually the Kohlberg paper that had compared amphotericin to voriconazole. And as you can see here, numerically, only a 6% difference, but essentially no difference. This was not statistically different. So certainly voriconazole could be an approved agent for candidemia. And then there were the key echinocandin trials, right? And the one that we've put up for you is the Riboli paper. The Riboli paper was a non-inferiority trial, but it had nested superiority built into it. And it's really important to know that not only did it meet the non-inferiority criteria, it actually met the superiority criteria. So this was anadulafungin compared to voriconazole. So the echinocandins have certainly exploded in terms of therapeutic options. And I've just kind of summarized the echinocandin trials for you here. This was the Mora Duarte paper looking at caspa versus amphotericin. It met the non-inferiority criteria, but it was much better tolerated. 58% adverse events in amphotericin, only 29% in caspofungin. The second key paper was micafungin versus liposomal amphotericin for candidemia, and again, met the non-inferiority criteria, very effective, 89 versus 89%, but side effect profile again favored micafungin, 4% versus 7.5%. And then I just shared with you the anadulafungin fluconazole paper, again met not just the inferiority criteria, but the superiority criteria. Now, the one thing I should mention, it's really important, is that most of these candidemia trials that were done in non-neutropenic patients. The proportion of neutropenic patients was really small in these trials. And so that's just something to be aware of, that though we extrapolate the data, depending on how you look at evidence-based medicine, there's a question. The only time that we've had really dedicated studies for echinocandins in the neutropenic patients were for the empirical febrile neutropenia studies. But for the dedicated candidemia trials, they've primarily been in the non-neutropenic population. Just something to keep in mind. This is just, I keep coming back to the anadulafungin fluconazole because people sometimes forget that it actually met the superiority cutoff. And the reason this was really important is this is a study that actually had patients with fairly high Apache scores. So because of this data in my center, what we have done is that we actually have two echinocandins. We have positioned anadulafungin as our primarily ICU echinocandin based on this Riboli paper, because it dealt with patients with high Apache scores, and it, as you know, does not require dose adjustment for either renal or hepatic impairment. But we have reserved caspofungin as our neutropenic treatment of choice. We don't do a lot of empirical febrile neutropenia coverage because we are a preemptive center. But if for some reason you need to use an echinocandin on a hematology ward, we use caspofungin. There is a plethora of guidelines. I just wanted to list them for you that you can pick and choose what you'd like to see. There's IDSA guidelines that were updated in 2016. There's Canadian guidelines from 2010. There's the ESCMID guidelines for non-neutropenic patients. And then there's the ECIL group, right, that exclusively deals with cancer patients and transplants, who have also updated. ECIL 6 was the last update for them. So just for the IDSA guidelines, because that's one I think that a lot of people do look at, it has changed, right? So I need to highlight that in this update from 2016 compared to, let's say, 7 years prior to that, the biggest change was that the echinocandins became first-line therapy. In the previous iteration, they still recommended that for most people, use fluconazole, only use an echinocandin for the very sick and patients with comorbidities or intolerance. Now, the recommendation is that you should use an echinocandin essentially for all comers as a loading dose, that induction de-escalation strategy. And that's what we do. And it's got to do with that shift that I showed you in Canada. I'm sure you're seeing the same thing in Saudi and in Lebanon and other places, the shift from albicans to non-albicans Canada that we're seeing, right? And by the way, that recommendation holds up for both non-neutropenic and neutropenic patients, okay? What about ECIL, which deals exclusively with cancer and transplant patients? So they have, again, given all the candins for the overall population an A1 indication, and A1, which means, again, strong recommendation, but based on observational studies, have both mica, anadulafungin, and caspofungin have all been given the A2 recommendation. Liposomal amphotericin, as I keep coming back, it may have challenges with tolerability, but it's still our go-to drug. A1 indication for all comers, A2 for hematological patients. Now, remember that case? I asked the question, would you have prophylaxed this patient? So I'm sure for those of you that have been in practice for a while, we've gone through a bit of a journey, right? There was a lot of discussion 10 years ago about trying to prophylax all ICU patients with antifungals to prevent invasive candidiasis and candidemia. And then, as you know, we've come full circle and realized that it's not effective. So I just wanted to summarize the data that the only group that's left where you should consider, and certainly we do that here, antifungal prophylaxis is in the subgroup of ICU patients who come in with visceral rupture. So people with abdominal surgery who get gastrointestinal perforations or an anastomotic leak, that in that group, yes, there is, the strength of recommendation is B, and the quality of evidence is actually quite good. So we don't do it for all comers in the ICU, but certainly for patients that come in with anastomotic leaks, we do support the use of fluconazole prophylaxis. So be interested to hear what you do in your center. They've listed Caspo as an alternative, but the study was really done. So I just want to take you back to the case. What did we do in that case? We started the patient on caspofungin. We got our germ tube result. It was negative, but the blood cultures remained positive on day 4, and it was worked out to be a glabrata. Surprise, surprise, right? You saw the emergence of glabrata in our epidemiological data. The fluconazole MIC was 64, amphotericin B MIC test was 4, and the caspofungin MIC by broth microdilution was less than 0.12. Obviously, the concern was not so much the failure from the drug, it was a source issue. Central line was removed. So I could not do a talk on invasive candidiasis and candidemia and not mention Candida auris, which I'm sure would have come up. So as you can see, this is now a global issue. This is just a reference that I've left for you. It's a really nice summary of something like just under about 5,000 cases of Candida auris globally. And as you can see here, no part of the world has been spared. But certainly, we're seeing some very high rates in certainly equatorial Africa, certainly in the base. India, right? Despite, it's going through all these challenges. And on top of that, obviously, it has seen a large burden of Candida auris. As you know, the issue is pan resistance to certainly most azoles. It retains susceptibility to micafungin and anadulafungin, but tends to be fully resistant to caspofungin. So certainly it'd be interesting to hear your experience around that. So just in the interest of time, I'll stop there, and I'm happy to take any questions or comments.
Thank you so much, Dr. Sharik. And please, Dr. Abir, can you comment?
Thank you, Prof. Haider, for actually raising very interesting aspects about candidemia. We're not aware previously about the. I'm very interested about your point about the receptors. You know, the gene, the receptors deficiencies in some of the entities. And their correlation probably with specific, I would say, immune deficiency. Probably I would say primary immunodeficiency. My question to you, would you consider this workup for immunocompetent individuals, especially with recurrent refractory mucocutaneous candidiasis, you know, especially with females patients, with some of them have really recurrent and refractory vaginal candida infections. They're failing most of the therapies. They don't have the usual, you know, risk factors like diabetic or, you know, the usual immunodeficiency. So would you consider them for this sophisticated work of underlying receptor deficiency? And
I think that's a brilliant question. And I think, you know, obviously we very much try to be cost sensitive in our diagnostic testing. So I think the answer would be, you know, the first time that you see them, you obviously want to make sure that you've got the right diagnosis. You know, not that you guys would get the wrong diagnosis, but sometimes we get referrals for recurrent mucocutaneous candidiasis that actually isn't recurrent mucocutaneous candidiasis. So I think once you get past that, then the next question always becomes, was the appropriate treatment given in the previous, you know, iterations? Because often you find, I'll give an example, subtherapeutic dosing for esophageal candidiasis as well. You know, it's not going to respond to 200 milligrams of fluconazole, right? So once you get past that, then we do initially a preliminary screen, which is not to this level of depth, which is just involves CD4, CD8 subsets, because as we all know, the single most important driver obviously would still be compromised T-cell immunity. So we do CD4, CD8 subsets and quantitative immune globulins to see if they've got a selective IgG4 subset deficiency. Once we get that back, assuming it's normal and the patient has not responded to the intervention that we've put in, then absolutely I work in a clinic, just happen to be lucky that we work with immunologists. So we actually have a shared clinic. It's just, it's like a few steps over. So we have a number of patients that we share back and forth. And now with I think what I wanted to highlight, and thank you for bringing it up, is I think this may be somewhat under-recognized, that there is this emerging group of patients out there, because you may go through an entire practice of 30, 40 years and never see someone with a STAT3 deficiency. You know, I've got 3 in my practice, right? I've got all these patients now with IL-17 inhibition, but you may never see them. So I think you're highlighting the fact that often we don't do this additional workup. But I also want to be cautious that I'm not suggesting for our junior trainees and staff early on that for every patient walking in on the first presentation that we sent off this level of intricate workup. But absolutely, once you've gone through those steps, 4 or 5 steps, and you still see persistent recurrent symptomatic cutaneous candidiasis, absolutely, I think a referral to your immunology colleagues is a very reasonable thing to do. And I give you an example of this woman. I wish I could show you a video testimonial from her. She's beyond thrilled, because she lived through years. Remember, this was 6-7 years of this thing, and no one had actually made the link. She was just being treated like she would get these episodes, you get a course, and I mean, this was horrific. And finally, if we had not taken the discussion with the dermatology colleagues, she would actually have just, this would have been an ongoing saga. And finally it took a collaboration to say, hang on, good news is that there's alternatives to anti-IL-17 agents that will do just as well for psoriasis. And we can make a difference here.
True. The problem with these patients on biological therapy is that people would concentrate, on PCP, invasive aspergillosis, toxo, and like these serious opportunistic infections. And they would not really realize that even a simple, or as you correctly mentioned, like a bad mucocutaneous fungal infection is making their life really miserable. And this specific correlation is somehow forgotten, like the biological agent is actually causing these refractory cutaneous fungal infections. Going back to your case, which is, again, it's a very common case that we tend to see in the ICUs, surgical trauma patients. And my question too is regarding, in the era of antifungal stewardship programs, and we're trying to reduce the use of echinocandin in the ICU setting. So to tell you the truth, we're not really practicing, I would say, the the principle of prophylaxis, unlike, hematology transplant population, but we have really a low threshold to start antifungal therapy. I would say probably empiric or even preemptive approach. Fever, and then multiple sites of candida, urine, sputum, then people would start with echinocandin. The difficulty is that, as you correctly mentioned, blood culture, most of the time, you're lucky that your patient, had a positive blood culture, probably because of splenectomy, visceral involvement, but multiple times blood culture is negative. And, you start echinocandin, intensivists are happy, patient is improving, fever is settling down, tropes coming down. And the difficulty is, would you continue like a full course of 14 days of echinocandin for a presumed high-risk patient? And like doing the beta-glucan testing, you mentioned it has a very good negative predictive testing. Like in this setting, if you do the test and it's negative, would you be happy to say, oh, we need to stop the echinocandin at this point in time, I'm not going to continue anymore?
Those are great questions. And I think I just wanted to make sure I was clear on what I had said earlier, that we don't do routine prophylaxis for all ICU patients. We only do it for the subset anastomotic leaks that come in. That's the only group that gets prophylaxed. The other thing that I'm sure, as you said, stewardship is it's established in every center these days. So I'll just share with you our experience here. So we do ICU rounds twice a week, on the Monday and on the Thursday. And we review all the patients in the ICU in terms of their anti-infective therapies. I can tell you that certainly in my center, we don't have liberal use of antifungals. In fact, I can't remember the last time we sort of empirically or preemptively threw on Candida for a fever. In fact, what we have done is, through these ICU stewardship rounds, is a lot of education around the fact that, the good news is, and we have to be fair about this, that there has been an improvement in our diagnostic yield for Candida. It's not perfect, but certainly automated blood culture methods have gotten better. So I think that's one aspect. The second aspect is that, the reality is, you're right, that we don't have good prediction scores in the ICU to differentiate the patient that does or does not have invasive candidiasis and candidemia. But we certainly have diagnostic tests that can solve that discrepancy. And I think beta-1,3-glucan is a classic example of a test that if you are in a center that tends to use early preemptive therapy, then you certainly should be a center that should have beta-1,3-glucan available, because that should be the strategy that you started on. It's a Friday, the patient's sick, fine, but you send off your beta-1,3-glucan, it's negative. On the Monday, that patient's antifungals come to an end. Because the reality is that we do know, remember from I know you know this, but for the rest of the folks on that are junior staff, that we went through an era where prophylaxis in the ICU was prevalent. And then we saw the negative downstream effects of that. It took 8 to 10 years to see the effects of that, but we saw it in the emergence of high-grade non-albicans infections in the ICUs. And so it would really worry me. So, you asked your question, I'll answer it very quickly. No, I would not give 14 days. I would do everything to de-escalate this patient very quickly, because again, I think our culture methods have improved. I think there'll always be a select group of patients that are culture negative. But I think with better diagnostic tests like beta-1,3-glucan, you should feel confident in de-escalating these patients. And I always say this with the greatest respect, that this is a generalization. Obviously, it's going to be case specific. It's going to depend upon, all these nuances. But as a general principle, we're trying to discourage a preemptive. We certainly don't here do preemptive. It comes up, by the way, so I don't want you to think it doesn't. It comes up on every stewardship round. In every patient discussed, should we throw this patient on caspofungin? And we say, well, let's talk about this. So why would we throw this patient on to caspofungin? And then the discussion always revolves in the end around fever. And we say, well, we're treating a fever here. Hemodynamics haven't changed. The vent settings haven't changed. We don't have the other thing that, as I'm sure you're gonna agree with me, the one thing we have to educate the ICU on is that they jumped all over this issue about multiple sites of colonization. Am I right? Do you hear that a lot in your ICUs from your ICU staff? And
yes, definitely.
One of the things that we do in our stewardship rounds, which has been, I think, advantageous for us, is that it's not just stewardship rounds. Every second week, we do an educational session for them. And so we purposely take the cases where questions like this have come up, and then we build that into an education. So I'll give you an example. So it took a while for, there was like this light that went on for the ICU docs when I could tell, because I know them, I've known them forever. And though they weren't saying anything to me when I was presenting, I could see in their eyes that, you see, they had forgotten that the data for colonization was not just the number of sites, it's actually an index. It's an index. It's called the Canada Colonization Index. It's based on number of heavy inoculated sites divided by the number of sample sites. They had just pulled out from that paper the fact that if you had multiple, there's no correlation between the number of sites and the risk of invasive candidiasis academia. So I just give you a small example that these small victories make a difference. And once we did that educational session, I can tell you I didn't hear Canada colonization come up on rounds for weeks to months. It was quiet because I think we had addressed a gap that existed, and that was something that had been embedded, right, about the need to start empirical therapy because I've got it from my sputum and so forth. I mean, we would always say to them, listen, I absolutely agree. We should be repeatedly doing repeat blood samples. Let's go looking for it. Obviously, if it's there, it needs to be treated. But this concept of, trying to correct some of these misconceptions.
Okay, I have one question from the attendees. Liposomal amphoby is extremely expensive in developing countries. Shall we consider combination therapy, fluconazole plus amphoby in a lower dose than it's recommended 3 milligram instead of 5 milligram per kg?
And may I just ask to clarify for which indication? For mucormycosis, aspergillosis, what specific indication?
I think during this COVID, I think for mucormycosis.
For mucormycosis, okay. Well, I think it's an interesting question, and the quick answer would be no, and I'll answer why. So we do have studies for mucormycosis that have shown us that escalating doses of amphotericin is associated with poor outcomes for mucormycosis. So this idea of, not for aspergillus, for mucormycosis, that using lower doses below 5 mg per kilogram, that going from 3 to 5 is actually associated with lower poor outcomes. So for that reason, though I understand the question about cost sensitivity, I would say I would encourage you to avoid that strategy. The flip side, I guess you're going to say to me is, but I live in a center where I see a lot of non-rhizopus, non-mucor. I'm worried about resistance to azoles, so I have to use ambisome. And my messaging would be, well, if you have to use ambisome, at least you have to use the right dose. And at minimum, it needs to be 5 mg per kilogram. In most cases, it needs to be higher to treat it. And remember that mortality signal, 80% versus 50% for a delayed effective treatment by 6 days.
Yes. One more question. Should central venous catheter be removed in a neutropenic patient with candidemia?
Great question. And so I'll answer it right away and I'll explain it. The answer is absolutely. It needs to be removed. But there's always been a lot of controversy around that, right? It's interesting. We don't share this with the hematologists. I just share it with you guys. That to be fair to them, if you looked at the randomized control trials for candidemia, the anadulafungin fluconazole paper, the Casco amphotericin paper, the mycofungin paper, in those randomized clinical trials, they were not able to show the effect of catheter removal on outcomes, right? We don't tell the hematologist that. The data that we have that catheter removal associated with fever was actually based on retrospective observational data. But as a universal recommendation, we all know from our experience that without removing the catheter for candidemia because of biofilm formation, etc., the probability of success is impossible. So the quick answer is certainly in my population here, we absolutely remove the line, even if it's a tunnel line, even if it's Hickman or a Broviac, we still remove the line.
Okay. Is there a role for colony-stimulating factor to enhance the immune response during treatment of invasive fungal infection?
Yeah, God, you're such a brilliant group of attendees. So I think, again, it depends on the context. So I'll give you an example what I mean by that. Obviously, you cannot do that, or the hematologist will be very upset sometimes if there's a reason why we don't give GCSF in all febrile neutropenics on the AML floor, because unfortunately, not only will you stimulate their normal cells, but you would stimulate their leukemic cells. So there's an inherent challenge in using GCSF in all patients, but let's leave those patients out. If we're just talking about, let's say, the ICU, and you have a patient that has candidemia, or has invasive aspergillosis, is there a role for G-CSF in the neutropenic patient? And the answer is that those studies, unfortunately, have been done, and the well-designed prospective studies did not show a benefit in outcomes. But as a general principle, rapid correction of neutropenia does have a survival benefit, but that was mainly in an oncology cancer population, not in a larger ICU population, because the one thing for our junior trainees to remember is that neutropenia is not an all or none, right? It depends upon the severity of neutropenia and the driver of the neutropenia. So my example would be that an HIV patient who develops neutropenia does not get invasive aspergillosis or invasive mucormycosis, but a transplant patient with the same absolute neutrophil count will get it. So it's not just a number issue, it's a functionality issue. Another example would be a hepatitis C patient who on interferon, which we don't use anymore, develops neutropenia. They don't get invasive candidiasis and candidemia. So it's just not just an absolute neutrophil issue. So it depends very much on the nature of that and the driver of that neutropenia.
Thank you so much. I think we have to wrap up our meeting today. It is very important to suspect fungal infection in ICU patient with fever for more than 3 days on appropriate antibiotic. And we have to know the epidemiological pattern of fungal infection, especially the local epidemiology to treat invasive candidiasis properly. I think there is no recommended duration for treatment of mucormycosis, and I think it should be tailored according to each patient. Do you agree with me, Professor Sharif, for this point?
I absolutely. I mean, I think patient-specific factors are always important. Right?
Yes. And we have to consider drug-drug interaction, especially when we prescribe azole antifungal group. Any addition from your side, Dr. Tariq?
No, thank you. No, I think this was a wonderful discussion, and we've learned a lot from Sharik. Thank you for your input, and thanks to all the commentators for their great contributions.
Actually, I have to thank Eva Pharma and Gilead companies for their support, and because they are the sponsor for this meeting. And I have to thank also ICOM Group for organizing this webinar. Thank you so much, Professor Sharik, Professor Tariq Madani, our elegant commentator, Professor Ahmed Saad, Professor Abir, and Professor Nasreen. And great thanks for Dr. Ahmed Kurdi and Dr. Reham, and for our elegant attendees. Thank you so much. We will see you next month, inshallah. Thank you so much.
Thanks very much. It was a pleasure. Stay safe. Good to meet all of you.
Thank you.
Bye-bye.